I'd like to begin by welcoming you to The Therapy Show, a podcast series that seeks to explain the leading forms of psychological therapy to the average person. We will be doing that by interviewing the professionals who develop those therapies so we can better understand when to use them and how to get the most from that therapy. Today, I'm honored to welcome Dr. William Miller, Distinguished Professor of Psychology and Psychiatry at the University of New Mexico, and founder of the therapeutic model, Motivational Interviewing. He is the author of many seminal books, including Motivational Interviewing, Helping People Change. Dr. Miller, welcome to the Therapy Show.
Hello.
Dr. Miller, can you start by telling us a little bit about your personal background and professional development that led you to developing motivational interviewing?
I originally started out heading into pastoral ministry, but found my way into psychology instead. And when I went to graduate school at the University of Oregon, it was a very cognitive behavioral program. But in the second year, they had a required year-long course on how to talk to clients. And it turned out none of the behavioral faculty wanted to teach that course. So they went over to the counseling psychology program and got an academic grandchild of Carl Rogers to come and teach us a person-centered way of being with clients. So I learned that before I ever had the opportunity to practice behavior therapy. It was a very fortunate experience for me because I always have practiced cognitive and behavior therapy in a person-centered style as a result of learning the blend in that order. And motivational interviewing really came out of my initial exposure to and work with the classic work of Carl Rogers.
How would you briefly explain motivational interviewing to a non-professional?
It's a way of helping people to find and voice their own motivation for change. It's kind of the opposite of trying to persuade someone to change. I find that when people are considering a change, our normal experience is ambivalence. Part of us can see the reasons to make a change, and part of us is comfortable doing life the way we've been doing it. And both sides are true. Both sides are there in the person. If I, as a counselor, argue for the change, for example, with alcohol problems where my work began, if I say, you have serious alcohol problems and you need to change, the person's normal response is, no, I'm not. No, I don't. And all I have done is to elicit from them the other side of their ambivalence. If I keep that up, if I keep pushing, I literally help the person talk themselves out of making a change, because we tend to believe ourselves when we hear ourselves talk more than we believe other people. Unfortunately, that is the way addiction treatment was being done at the time in the 70s and 80s, in a very authoritarian, confrontational, persuasive kind of style. And the natural response of clients to be defensive was then dismissed as pathological, being in denial, whereas it's just a normal outcome of that way of arranging the conversation. So motivational interviewing is a way instead of helping people to discover and voice their own arguments for change.
So when and how did you realize that motivational interviewing would be an effective form of therapeutic intervention?
Well, it took a while. I mean, the way it emerged is interesting. I was in Norway on my first sabbatical leave, and I was working at an alcoholism hospital there, actually hired to lecture on cognitive behavioral treatment of alcohol problems. But the director also asked me to meet regularly with their psychologists, most of whom were pretty fresh out of graduate training, and just have regular discussions and see what came of it. And I was happy to do that. And they wanted me to role play to show them how I would work with their clients. And happily, the psychologists spoke English, so they could portray their clients in English and just see what I would do in response to these fairly serious alcohol-dependent people. As I did that, as I demonstrated how I would go about it, and I had been teaching them both a person-centered approach and behavior therapy, as I did that, they would stop me. They would interrupt me, which my American students never did. And they would say, no, hold on a minute. What are you thinking right now? You asked the client a question, but you could have asked a lot of questions. Why did you ask that particular question? Or you reflected something the client said, as you've been showing us to reflect, but the client said a lot of things. Why did you reflect that particular thing? And they literally evoked from me this approach that I was not conscious of using, but I was doing, the essence of which is to arrange the conversation so that the client makes the arguments for change, and I'm not the person pushing for it. So together we kind of began to formulate what this is and how it works. I didn't go to Norway with any concept of anything like motivational interviewing. And that's a name that I assigned to this way of working with people because it's about the person's own motivation. And I like interviewing because interviewing is a power-neutral term. You might be an employer interviewing potential employees, in which case you're in the upper power seat. You might be a lowly college student interviewing a famous visitor, in which case you're in the lower power seat. But interviewing is just different from conversation. You have a different role from the person whom you're interviewing. So it just made sense as a name to try to describe what we were looking at. I had no idea if that was an effective approach at the time. To my surprise, one of my colleagues wanted to publish the article. I just wrote up a discussion of it, sent it around to colleagues to say, what do you think? And he said, I want to publish it. I said, I have no evidence at all that this works. We just kind of made it up here in Norway, but he said, I think it's a good paper, let me publish it. And so he did. I thought that's the last I'd hear about it, and in fact, it wound up taking over my professional life.
So who is motivational interviewing most effective for, and why would people choose motivational interviewing for an effective intervention?
Well, if you're working with someone who is ambivalent about change, and that's the normal human situation about change, that's where it's particularly useful. If someone comes into your office, they've already made up their mind, they want to quit smoking or whatever it is. I know I want to do it, just tell me how. There, you usually proceed to just help them make the change if they're wanting to. But what I quickly discovered in addiction treatment, and then more generally in practice, is that most people coming in to seek help or encouraged through the door of someone to seek help really feel two ways about it. They're not sure they want to do this. And helping people to work that through, or kind of get through that ambivalence and really make a decision to move ahead with change is where this is most useful. On average, it works just as well as cognitive behavior therapy, which we found later in a big comparative trial, and worked just as well as a 12-step oriented approach in helping people with alcohol problems on average. But it's people who are less sure or ambivalent or more resistive or defensive or more angry who seem to respond particularly well to this approach.
So what's the average length of treatment for somebody working with a motivational interviewing modality?
1 or 2 sessions is the normal length of motivational interviewing itself. I had originally thought of this as a kind of preparation for treatment. And indeed, you can start with motivational interviewing and then transition into a cognitive behavioral approach or whatever else you do. Our surprise in some of the earliest studies was that people went ahead and made the change having had an interview of this kind without any additional help from us. And that kind of shocked me because I'd sort of been trained to think the longer you spend with me, the better you're going to get. But in fact, it seemed like once you help people get over the hump to make up their mind or resolve their ambivalence, they often have the resources to go ahead and do it. If they want additional help at that point, fine. We've got a whole panoply of evidence-based approaches for helping people to make changes in addictive behaviors or whatever problem they're bringing. But the surprise, which should not have been a surprise, I think, was that often people have the resources to do this themselves. And in fact, most people who change addictive behaviors do it without ever seeking treatment.
What skills, habits, or tactics can patients and therapists adopt either during their sessions or in between sessions to improve the effectiveness of motivational interviewing?
It's a way of being with people. I've been saying lately that motivational interviewing is a way of doing what else you do. So it's a person-centered, empathic, accepting, listening, respectful, strength-focused attitude, in a way, toward whatever the rest of your work is, whether it's primary health care or diabetes education or psychotherapy or academic counseling or whatever it is. So there's a particular set of skills that one learns in learning a person-centered approach like motivational interviewing. And then it's a matter of learning how to use those in what else you do. So it's like learning a musical instrument in a way, or learning to play a sport. It's something you get better at over time, but you only get better at it over time if you get some feedback or some coaching from somebody who's a little better at it than you are. That's what you do if you want to learn tennis. You engage a tennis coach to just watch you for a few times and give you some tips. And you never say to the tennis coach, "Don't watch me, I'd be too embarrassed," or to your piano teacher, "But don't listen to me because I'd be embarrassed." It's by listening to you or by watching you that a coach can help you get better at it. So I learned that the hard way by evaluating my own 2-day workshop on motivational interviewing. And what we found, I got tapes of actual practice before and after my 2-day workshop. What I found was very little change in actual practice behavior and no change in the way clients were responding. However, people who had the workshop were now persuaded they had learned this and were doing it in practice, even though there was very little evidence on their tapes that I had even been there. So that taught me something, that a workshop is not enough. I don't know why I ever thought it would be, but just sitting and listening and practicing a little bit in a workshop is probably not going to change your practice behavior. So then the question became, well, what does it take to help people learn this? And it turns out it's feedback and coaching, that if you can get it, doesn't even take a great deal of it. I think we had in our first trial on average 6 half-hour coaching sessions on the telephone. But it made a huge difference in the proficiency of people after the workshop. So it got me into a terrain I hadn't planned on investigating, but just that initially shocking finding that the workshop made no difference in practice skill led me to say, well, how do I help people learn this then? Because that's not their fault, that's my fault if they didn't learn it over the course of my training.
So what are the most common obstacles or missteps that prevent therapists and patients alike from seeing the full benefits of motivational interviewing?
The expert role, the idea that we have the answers for people, and that kind of gets trained into you in graduate training where you're supposed to have the answers all the time. But it's the idea that I'm the expert here, and if I ask you enough questions, and if I collect enough information from you, then I will have the answer for you. And that turns out not to be true very often when what you're talking about is lifestyle change or behavior change. And the person who knows the most about how to do that in their own life is the client. And nobody has more experience with them than they do. So it's kind of letting go of the somewhat unhumble way of thinking that I'm a dispenser of expert knowledge and wisdom and insight and skills and so forth, to let go of the message, I have what you need, and I'm going to give it to you. And instead, approach practice with the thought of you have what you need, and together we're going to find it. So it's a sharing of expertise. So I think that's the first obstacle that occurs to me. It's really an attitude. It's really how you think about what you're doing. And Carl Rogers was all over that. He talked about the therapeutic attitude as such a big determinant of outcome. Getting skillful at reflective listening is a fundamental skill without which you really can't do motivational interviewing. And it's something that looks easy, or people who are good at it can make it look easy. But when you actually begin to try to practice reflective listening, you discover it's not as easy as it looks. And it, again, is something that you can get more skillful at over time with practice. That when someone comes to us already pretty good at Rogerian accurate empathy, the skill that Rogers called accurate empathy, learning the rest of motivational interviewing is relatively easy. But that often is what takes the longest time to learn. When I had to hire a bunch of therapists to do motivational interviewing in a clinical trial, I pre-screened them for the ability to do reflective listening, because I knew if I had to teach them that and motivational interviewing, I wasn't going to have time. And it worked out really well.
So can you share any poignant examples of where motivational interviewing had a major impact in someone's life?
Well, there are a lot. We've done large clinical trials, so we're talking about hundreds and over the course of my career, thousands of people. but I also treated people personally, and so remember particular situations where it just seemed to be a turning point for people, and in a relatively short period of time. I remember a fellow I worked with who had been pushed through the door by his wife, who said, "You have to do something about your drinking or I'm leaving and taking the kids." And he didn't want to be there. But I met with him a couple of times. I did a little bit of assessment with him, looking for some of the early effects of alcohol on brain functions and life patterns and so forth. And then we just kind of talked about what he was experiencing. He realized his drinking had pretty much crept up over the years, and he hadn't been paying a lot of attention to it. We figured out that he was driving to work in the morning still intoxicated because of the amount he'd had to drink the night before, which he didn't realize. He had nothing to drink in the morning, but had he been pulled over, he would have been arrested for driving under the influence. So things like that just kind of got his attention. And so then with this person-centered style, I just said, "Well, so what do you think you need to do at this point? Where do you want to go with this?" And he said, "Well, I think I need to quit drinking. I think I need to let go of it," and which he did. Now, he had a few occasions of drinking a little bit for a few days when he came back hanging his head, and he said, "I had 4 drinks this week." And I said, "Well, you used to have 80 drinks a week, so that's pretty good progress. What do you want to do now?" "I'm going to go back to not drinking again." "Okay." But he did stabilize over the subsequent year or two. It wasn't more than this kind of conversation, recognizing that he has the power to decide what he's going to do and how he thinks about his drinking. And my job was just to be there and facilitate it. So there's just an endless series of examples like that. Conversations that honor the person's autonomy, help them to think through what they already know, essentially the pro-change side of their own ambivalence, and not get in their way by telling them what to do.
So who is motivational interviewing not appropriate for?
Well, you don't really need the evoking piece of what we develop if somebody's ready for change. So if somebody comes in and says, "I want to stop smoking," that's not a time to be Carl Rogers and say, "Well, what have you liked about smoking in the past, and why might you want to do that or not do that?" And the person's kind of past that reflective stage and ready to move on, and so you move on. You might subsequently find that they are still reluctant and have some reticence about it, but if they're saying, "I'm ready to go, let's go," you go. So that's one group of people. We've looked for diagnoses where it doesn't seem to help. We thought for sure that it wasn't going to help people with sociopathic tendencies because of the stereotype that people with sociopathy don't form relationships, and this is a relationship-focused approach. And yet we found in the biggest study we ever did that sociopathy did not predict anything about how the person was going to respond to this. People with higher sociopathy scores responded just as well as others did. Psychosis, well, maybe schizophrenia, it's not going to work too well. To the contrary, there's pretty good evidence for improvement in medication adherence and decreased rehospitalization. We don't know how old kids need to be before they themselves respond to this. There probably is a developmental level, a cognitive, emotional developmental level that one reaches before this really kicks in. But if kids are young enough, 8, 9, 10, you really need to be talking to the parents anyhow. And we know that this works with kids who are 16, 17, 18. So maybe there's an age gradient in there. That one we're not too sure about yet. But we haven't yet found a DSM diagnosis where, never mind, this isn't going to work. We thought it was tobacco smoking initially because the first few trials were not very encouraging. But subsequently, there's a slew of positive trials. And there are now meta-analyses saying motivational interviewing is an evidence-based tool for helping people quit smoking. So there are more than 1,100 controlled trials in the literature now of motivational interviewing, which I find astonishing. And it's been tried with all sorts of things. And it's not a specialist technique. It's a generalist skill.
So what are you most excited about in mental health treatment today?
10 years ago, I would have said the movement toward evidence-based treatment, the kind of increasing expectation that treatments that are being provided by counselors and psychotherapists be methods that have a good scientific basis. That's what we expect of our healthcare providers more generally. And it's a reasonable thing, although not a simple thing to do. So more and more states and third-party payers are beginning to require that people at least say they're using evidence-based treatment. But there's the rub, that knowing whether people really are requires that you audit, listen to sessions, and know what's going on. It's pretty hard to tell from case notes. But now what I'm excited about, I think, is increased awareness of the impact, the large impact of therapeutic relationship. I think emphasize too much treatment techniques or evidence-based techniques. And here's this manual. If you just follow this manual, people will get better. Well, it turns out that within any theoretical orientation or any particular treatment technique, there are large differences in client outcome based on who's providing it. And we know something about what that is. I mean, what is it about providers that makes it more effective? And when you compare different theoretical orientations of psychotherapy with each other, or different specialist psychological techniques with each other, they're pretty similar. You don't really get very big outcome differences. In that one big study I alluded to, we randomly assigned people with alcohol problems to motivational interviewing or to cognitive behavior therapy or to 12-step facilitation. And all three finished dead even. The outcomes were very good overall, without much in the way of difference among the three. But within each of the three, large differences based on who the provider was. So if anything, what is most likely to predict a client's outcome is the counselor with whom they work. And we're becoming more aware of that again, which is exactly what Carl Rogers was thinking and writing about in the 1950s and 60s. And I think that's an important advance over just thinking, brand name techniques or this particular manual or whatever. There really is no evidence that I know of that following a therapy manual makes treatment more effective. In motivational interviewing, in fact, one meta-analysis found the opposite, that when the therapists were following a manual, the effect size was 1/2 as when therapists in other studies were not following a manual but doing motivational interviewing. And that makes perfect sense to me, because if you're paying more attention to a manual than to your client, you're not doing it right.
So if you had a magic wand and could improve one thing about mental health treatment today, what would that be?
To humanize mental health treatment, to have practice become more empathic, more respectful of clients' autonomy, more interested in their strengths and less interested in their pathology. The positive psychology movement has I think, gone in that direction. There's something else I'm excited about. We spend an awful lot of the history of psychology studying what's wrong with people. And now, within positive psychology at least, you're interested in, what is happiness about? And what is it that actually makes people happy? What are virtues? I mean, how do you become honest? How do you become kind? What's that look like? How do you do that? I think that positive mindset that looks for what people are doing right and looks for their own wisdom and resources is so important. And I hope that that's an impact. I know it is in addiction treatment, an impact that we wind up having on healthcare more generally, a humanizing effect.
How can my audience learn more about motivational interviewing, either online or in print?
Online, the Motivational Interviewing Network of Trainers maintains a website with more than you want to know. It is www.motivationalinterviewing.org. It will point you to lots of resources there. There are 30-some books around now about motivational interviewing. The one that Steve Rolnick and I wrote is now in the 3rd edition. It came out in 2013, and that's kind of our current state of understanding of what's going on. There are books in specialty areas. I wrote one on motivational interviewing in diabetes management. There's one on motivational interviewing in healthcare. There's one on working with kids, with children and adolescents. There's one on applying motivational interviewing in corrections. I mean, just all these particular areas where people have done the work to understand, when I'm working with this population with brain injury or whatever it is, what is it about motivational interviewing is helpful, and then have shared that information. as I said, there are more than 1,100 clinical trials out there, so we have an enormous amount of research, and what most people want to do is read the distillations of that, the meta-analyses or summary reviews of that. And there are more than 100 of those now, so the extent to which this has grown is just astonishing to me. I don't think it's grown primarily because of the science. The science has grown, but I think it's that providers, it's like they recognize this, and they begin to hear about and understand it as if it's something they already knew and wanting to understand more about. And that seems to be what draws people to this. And this is all around the world now, where it's in more than 50 different languages being taught and practiced. So I think there's something fundamental about human nature going on here that we just happen to tap into. And it's been great fun to watch that. But there's no end of sources of information. But also on the motivationalinterviewing.org website, there's an ongoing list of trainings that are available by geographic area. There's lots and lots of those, introductory and advanced and trainer level. I know that just reading about it doesn't usually change practice behavior. I learned that just going to a workshop doesn't change practice behavior, although you might have the illusion that it does, and that usually it takes some practice with someone looking over your shoulder and making gentle suggestions, just as is the case when you learn a musical instrument or a sport.
Dr. Miller, on behalf of myself, my listeners, and all of the people you have helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience to better understand the field of motivational interviewing.
You're most welcome.
I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so that you, someone you love, and the people around the world can gain benefit from therapy like motivational interviewing. There is no need to suffer in silence. Get the help you need to create the life that you want.